Good morning, everyone. This is Sunny Lou Williams here. Thank you for joining the fourth edition of the Division of Mental Health Addictions funded Cultural Linguistic Competency Project, focused on technical assistance webinars covering a wide range of topics in support of our mental health and addiction providers. This morning, it is my pleasure to introduce Kelly Meyer to speak on intersectionality in health, key concepts and considerations for mental health and addiction professionals. So Kelly Meyer is the president of Kelly Meyer Training Solutions since 2011. Prior to that, she worked 9 years for the National Alliance on Mental Illness. Kelly has developed trainings on culture, communication, understanding mental illness, which is a Indiana Law Enforcement Agency certified course focused on teaching cultural competency and overall mental health support to first responders in law enforcement, and key topics for frontline staff working on emergency response teams, hospitals, nursing homes, home health care, corrections, jail staff, law enforcement, community corrections, parole, probation, work release, the courts, community health workers, and many others. Kelly has worked extensively to establish CIT, which stands for Crisis Intervention Teams, and emergency response teams, and to prepare them with de-escalation techniques, cultural awareness, and an understanding of mental illness and related topics. In 2010, Kelly co-developed CIT for Corrections for the National Institute of Correction, and in 2019, in partnership with the Center for Naval Analysis, Kelly revamped the 40-hour curriculum. Kelly has served as an advisor to the International Association of Chiefs of Police in Alexandria, Virginia, to help establish policy enhancing officer safety as related to mental illness. Kelly has also developed programming directly for consumers of mental health services to better understand their illness as well, and to work in peer support for others with mental illness. Kelly is currently a partner with TechServe Corporation to deploy statewide cultural competency training for the Division of Mental Health and Addiction in Indiana, as well as training frontline response teams to the opiate crisis across the state of Indiana through development of mobile integrated response teams. Kelly holds a Master's of Arts degree in Executive Development for Public Service from Ball State University, and I'm thrilled to introduce her today in providing an overview of intersectionality and health in support of our Cultural Linguistic Competency Project. Kelly, thank you for being with us.
Thank you very much, Sunny, and thank all of you very much for joining this webinar today. It is my sincere pleasure to be part of this project. Today, in talking about intersectionality, we are going to define and understand it. We're going to analyze stigma and political correctness and explore best practices that remove barriers to recovery. We will comprehend how our biases, preconceptions translate to others, and initiate strategies that culminate into first-person speaking and actions reducing stigmatizing practices. To understand intersectionality, what is it? It's a theoretical framework of understanding aspects of one's social and political identities combine to create unique modes of discrimination. So it's not just looking at one aspect that an individual is born with, it's looking at a combination of traits. So beyond looking at simply gender, we may look at gender plus race, or gender plus class, or race plus sexuality, or race plus disability. So any combination of these combined is what we'll be discussing and understanding how we may be looking at folks who are marginalized in society today because of their race, their gender, their sexuality, their class, their disability, their group, and so forth. How did this term intersectionality come about? Kimberly Williams Crenshaw introduced the theory of intersectionality in 1989 in her paper written for the University of Chicago Legal Forum. This paper was titled Demarginalizing the Intersection of Race and Sex, a Black Feminist Critique of Anti-Discrimination Doctrine, Feminist Theory, and Anti-Racist Politics. The main argument of this paper is that the experience of being a Black woman cannot be understood in terms of being Black and of being a woman considered independently, but must include the interactions between the two, which frequently reinforce each other. So, a lot of times when we're looking, demographics are analyzed by each trait and not a combination of traits. So even when we look at how we serve the clients we do in our own agencies, or how we apply for various things and do studies, we are given a set of traits that we check a box, and it's one thing. One thing for race, one thing for gender, maybe a box for a disability, but are we looking at how many of those boxes are checked in combination with one another? So intersectionality is used to find those combinations of injustices that are felt by members of society. For example, a Black woman might face discrimination from a company that is not distinctly due to her race because the company does not discriminate, against Black men, nor her gender because the company does not discriminate against white women, but a unique combination of the two, which does somewhat inadvertently discriminate against her. So here are some additional publications that Kimberly Crenshaw wrote that you may find interesting, that you may want to explore this topic and her ideology a bit further. So it's interesting that just last week was a celebration of the introduction of intersectionality 30 years ago. So here is a tweet from Kimberly. Got caught up and forgot to tweet until I read someone call intersectionality dangerous today. So for those who want to really know rather than stereotype, try this. Kimberly Crenshaw on what intersectionality means today by Time Magazine. So here was a tweet and a question to her. You introduced intersectionality more than 30 years ago. How do you explain what it means today? And her reply was, these days I start with what it's not, because there's been distortion. It's not identity politics on steroids. It's not a mechanism to turn white men into the new pariahs. It's basically a lens, a prism for seeing the way in which various forms of inequality often operate together and exacerbate each other. We tend to talk about race inequality as separate from inequality based on gender, class, sexuality, or immigrant status. What's often missing is how some people are subject to all of these, and the experience is not just the sum of its parts. So let's take a look at this analytic framework. How interlocking systems of power affect those who are most marginalized in society. While the theory began as an exploration of the oppression of women of color within society, today the analysis has expanded to include many more aspects of social identity. Race and gender bias are two separate issues. However, they can be combined to create even more harm. Intersectionality is used to describe this phenomenon of being impacted and oppressed by multiple sources, but only treated for one. Now, it is difficult to measure due to its subjectivity in nature. So let's take a look at a variety of traits. Each of the following photos that you will see represents businessmen and women from stock art-free photos. I'd like for everyone to take a self-reflective moment to see if an emotion stirs positively or negatively with any photo. This exercise is meant to stimulate self-awareness for the remainder of discussion and not to be shared with the group. Gender, race, age, dress style, grooming style influence our opinion of others. So, how do we approach our own biases? Why do I think that? Why do I judge? Think of how very difficult it is for you to present your best self, trying to create the image society wants to see. Think of your clients and how difficult it is for them to present their best self. Why do we impose that image with that culture? Have we created greater disadvantages for some groups with these biases? When you meet your client for the first time, is there a knee-jerk reaction to what you see? Okay, we've had a reflective moment. Let's explore further. What's it like working as a group? Take another reflective moment to consider how you work in a group, how you work with the various people in which you work. What are their types, their differences, and how do you work collectively? Consider this. We've made a friend, and then we meet their significant other. Working in the human being business is challenging work. While our intentions are pure, how can we safeguard against demonstrating a bias, perpetuating stigma, inadvertently stimulating discrimination and well, first of all, let's define those words so that we understand what we're discussing here. If you've been part of this series, in our very first of this series with Dr. Rudnick, we talked about bias and implicit bias. And Dr. King reinforced that for us in the last session that we had. But let's review it a little bit today. Bias is a tendency, preference, or an inclination, especially one that inhibits impartial judgment. When we have conscious and subconscious processing of information, subconscious attitudes and behaviors are referred to as implicit bias. Social stigma is defined as the disapproval of or discrimination against a person based on perceivable social characteristics that serve to distinguish them from other members of a society. Social stigmas are commonly related to culture, gender, race, intelligence, and health. Oppression is a term often used in political context. Unfair or cruel use of power to control a person or group. Can we have value in bias? We can. For example, especially in the area where we work, we need to be sure that we're keeping ourselves safe. So sometimes we apply personal previous experiences with a client, family member, a part of town, etc., to our way of doing business. If we've gone to a place where shenanigans occurred, we may always expect shenanigans to occur. If we've met with a client who was perhaps violent with us or explosive in nature, if we're serving another member of that same family, we may put additional safeguards in place. So some biases we may have in place for our safety, and they may be warranted, but there are challenges with bias. We might make an incorrect application of assumptions or quick emotional decision making. When many Euro-Americans settled this country, they sought to preserve their heritage, but may have acquired biases along the way with that preservation. Various cultures may group together for comfort among peers to practice similar customs or to speak a secondary language. Outsiders may view the actions of one as actions of the entire group. When we define stereotypes, prejudice, and discrimination, stereotypes are a widely held but fixed and oversimplified image or idea of a particular type of person or thing. Prejudice is a preconceived opinion that is not based on reason or actual experience. Discrimination is the unjust or prejudicial treatment of different categories of people or things. Political correctness. We all struggle with this one. But if sometimes we ignore people when we're unsure of how to address them. We don't know how, so we just simply don't address them at all. We ignore them. Try to address them by their names. Find commonalities through conversation, but conversation that's genuine. You want to know a little more about them. You want to get them talking. It's like, how do I do it? How do I even approach their culture? Well, maybe you start with, hey, I grew up in Terre Haute. What was it like growing up in Evansville? Just a small example, but maybe an intro to some conversation. If we overemphasize a person's culture or characteristic while attempting to make them feel welcomed or included, they're sitting right at a table with you and say, oh, we don't have anything against you, well, whatever that differentiating trait is. We go out of our way to invite you people, sometimes to our gatherings, etc. Making food you think they'd like or other relatable acts, those are expressions of kindness, and they often make people feel pretty welcome. Calling out their different traits to others may emphasize how much of an outcast they really are. If sometimes we catch ourselves using hurtful language that we learned a long time ago and didn't realize its impact, practice better phrases so they're natural and sincere when you speak. So they just kind of roll off of your tongue. For administrators and policymakers, try to define appropriate and inappropriate language where you can so that fewer mistakes are made and the expectation is clear. If you're afraid to describe someone for fear of offending, basically in that description, if you wouldn't like to be called that label, chances are it shouldn't be a label. I look at words like old and young, which can be subjective. Try to be very specific. If you say that old woman and she's 40 years old, she may have a little exception to that when describing her. And I would know, even if you said that old woman and she happened to be old, she may not like it. So there are things like when you try to describe someone, say the young man in the red shirt, possibly in his 30s, if that's what it looks like to you, it probably looks the same to someone else. It's okay to add the color of their skin. If you're in an emergency situation, you're trying to get the best descriptor out of what that individual looks like. Try to be descriptive and try not to do it with a label. If you are uncertain how to pronounce someone's name, don't be afraid to ask the person how to pronounce it. You may have to do that more than once. It's okay to write it out phonetically until it becomes a natural pronunciation for you. If one person is different from the rest of the group, for example, 6 men and 1 woman, or 6 people of one race and only 1 of another, ensure that you invite or include that person to lunch or other activities. You've been working side by side with them, and off you go to have lunch. Don't assume that they'll know that they're included, and don't assume that they will insert themselves if they wanted to go with you. The stigma of mental illness creating barriers to recovery. This one has been challenging for centuries, and it will continue to do so for some time. But we're looking at that from differing perspectives as well, because we actually have the perspective of the consumer of mental health services, the family member or caregiver, the friend, a business associate, providers of mental health services, the public as a whole. And individually, we may think of mental illness in a particular way because we know that person, yet systemically, we may voice a different opinion. What happens when the stigma of mental illness is compounded by all of these other traits we've talked about, such as race, ethnicity, gender, sexuality, culture, group affiliation, or religion. Think of our own actions. When a friend or their family member goes into the hospital with an illness, a broken bone, do we take a casserole over to the home? Do we offer to run errands for the family? When a friend or family member is admitted for mental illness reasons, do we take that casserole over? Do we offer to run those errands? We can improve stigmatizing practices. Let's consider using first-person language. We'll start there and let's look at some examples. Homelessness. Do you say the homeless? Consider this. This is a person or persons without a home. When we say the homeless, we're really saying, oh, those people, or oh, those people, but still, oh, those people. The images we conjure when we hear that terminology oftentimes are negative. It also presents as a societal problem so large, we're not sure how we personally can help or make a difference. So we may potentially do nothing to help solve the problem. What if our words were someone who has lost his home or someone without a home? We put that person first. What if we use their names when describing them? John and Tracy live on the streets. John and Tracy have no shelter, no beds. Perhaps the societal problem can become a little smaller as we address individuals instead of a problem too large for one individual. Mental illness. Do you say the mentally ill? Consider this. These are people with a diagnosis. When we say the mentally ill or the schizophrenics and so forth, we are really saying, oh, those people. The image we conjure when we hear that terminology oftentimes are negative. It also presents as a societal problem so large, we are not sure how we personally can help or make a difference. So we may potentially do nothing to help the problem. What if our words were someone with bipolar disorder or someone with depression? Do we hear people say, oh, there goes a cancer, oh, there goes a heart attack, or oh, there goes a hip replacement? No, but we do hear and say, there's a schizophrenic. Let's skip that language and use first person language first. Our simple phrases can help destigmatize mental illness and reduce discrimination. Perhaps the societal problem can become a little smaller as we address individuals instead of a problem too large for one individual. Images of a person with mental illness don't become the images that we just saw, but they become your dad, your mom, your aunt, uncle, sister, brother, cousin, friend. Overcoming oppression. Oppression is when a person or group of people who have power use it in a way that's not fair, unjust, or cruel. But it can also describe the feeling of people who are oppressed. Let's do a little case study here, and we're going to take a look at a treatment team meeting. So who is attending my team meeting? And let's take a look at this table where everyone is seated, and here's the patient's empty chair right here. So we might have in this circle any number of these folks, maybe possibly even some more, but we have the psychiatrist, the psychologist, the nurse practitioner, the nurse, some social workers, job coach, education coach, peer support specialists. And we're waiting for the patient. So everyone in this first scenario, everyone is already seated at the table except the patient. Someone goes to get the patient, there's discussion, and the patient leaves. Do you think the patient truly feels a part of the team? Did he or she contribute fully? Does the patient automatically know where to sit? Is the patient directed to his/her chair, or do they need to guess? Is there sidebar discussion going on when the patient enters? How is the patient greeted? Is the patient a guest at a staff meeting, or is the team meeting really a team meeting for the patient? So now that we've considered that scenario, let's look at scenario 2. What if we have a series of team meetings, and in between those meetings, everyone of that list that we mentioned in scenario 1 who was seated at the table, everyone picked up their things and met outside the door, walking in together with the patient. Everyone, including the patient, chose their seats together at the same time. Everyone engaged in conversation, including the patient, as everyone entered the room, including the patient in generic conversation before the meeting. So we have something inviting and we've maybe established some commonality. Maybe you discussed the Super Bowl last night, or, oh, it was a snow day. How much snow did you shovel? Or, oh, it was so hot, I had to, do this. What was the, oh, tell me about that quilt. Did you finally finish it? How good was a particular restaurant? You don't want it too personal, but inclusive, but a little bit personal if you know, but something that everyone can feel a part of that conversation. What do you think? Is it possible the patient in scenario 1 felt oppressed? Think about your answers to this question. Do you believe the patient in scenario 2 would have a more positive response to treatment than in scenario 1, a less positive response to treatment than in scenario 1, no different response? I'd like to know what you think. I think we'll put up a little poll here. This is it possible the patient in scenario 1 felt oppressed? Once that poll appears, then just select your answer, A for yes, B for no, C for no opinion.
At this point, there's a 79% have answered yes, and 24%, it's dynamic and changing. So on the right-hand side of your dashboard, you'll see the poll in progress. 61% have voted, and we're overwhelmingly towards a yes, about 70% fluctuating, and then no opinion, 30% fluctuating. And one of our audience members has asked, could you please repeat the question?
Oh, yes. So the question is it possible to think the patient in scenario 1 felt oppressed? Very much for taking this poll. Let's look at let's do another poll. And this poll is, do you believe the patient in scenario 2 would have A, a more positive response to treatment than in scenario 1, B, a less positive response to treatment than in scenario 1, C, no different response to treatment than in scenario 1.
We are at 51% voted, and we are at roughly 70% for the first selection, a more positive response, and 20% at a less positive response, and roughly 10% at no difference in response. And we're now up to 62% voted at about the same.
Okay, thank you very much. These polls and these examples were intended to just kind of let us think a little bit about how we do our everyday business. We're all working so very hard, and we're doing so many good things, and we're doing those for our clients. That is there that one little thing that might make a difference in our day with our language or our actions, or something that might be just a little more inclusive that that you could personally do. So while these were a couple of examples. You may have several other examples or things that you do that that just really mean a lot for your patients and really help their recovery and stimulate those positive recovery. So think about all those little things that you do that have a very big impact. Understand the challenges that people have that are faced with multiple societal disadvantages. So let's go back to looking at, wow, they're born a certain way. They can't change those traits that they were born with. And what if we have certain biases, certain stereotypes associated with any of these, that when we combine them, it really adds to the struggle of our client. Recognize any implicit bias that may exist within you. Determine its origin and challenge yourself to focus on the individual before you. Please let's try to use first-person language to diffuse the stigma surrounding the clients we serve. And let's ensure that our intentions for inclusion are inclusive in our actions. And whenever we can, to kind of feel the struggle that our clients might have, if there's ever an opportunity that you could walk the path that your clients walk, those that we serve, to see if you would welcome the treatment that you receive. So let me say that again. Walk the path of the clients we serve when you can, to see if you would welcome the treatment that you receive. So I know we have such busy days and busy schedules, but sometimes taking this and even saying, and more than just an observation, but actually doing it, kind of gives us other little things. Oh, maybe we should do this just a little bit differently. That sure would be nice. Or, oh, I would have liked this, but they're so slight that you really don't think of them in the big scope of things. But in the small world of everyday just niceties, they just really, really, really have a huge impact and mean a lot. Thank you very much. I really appreciate all of you who joined today, and I hope that this has some impact for you.
I think we will close for this webinar session. Kelly, did you have any additional items that you wanted to share?
Only that I do know how hard it is to work with the different personalities, the different traits, the different things that people come with. And I just want to thank each and every one of you who participated today for the work that you do and the difference that you make in the lives of so many. So thank you all for having me and for signing on for this webinar. And I hope that there's a takeaway for you in it. So thank you so much.
Have a wonderful rest of the day, folks. Thank you very much for attending.
Thank you.